Now I think we have come to the last lecture of the Zoom series, vascular access in children. Although it sounds very simple, it is an important topic. As you all know, almost all the patients who are seriously ill need vascular access. When it comes to the children, it's particularly challenging. So you need to have skills on vascular access. So there are three ways of getting the vascular access. One thing is intravenous, which can be peripheral or central, or it can be intra-arterial or intraosseous. First, we'll discuss about the intravenous access. So what are the indications for intravenous cannulation? It may be to give IV fluids. Maybe it's a collapse patient, or you may have to correct the dehydration, or it may be a patient who is unable to tolerate orally. Then for blood administration of blood and blood products, and also for IV medication, intravenous access is needed. There are a few important principles that you have to keep in your mind before starting the procedure. Firstly, it be done under strict aseptic conditions. Safety is very important, both to you as well as to the patient. And also comfort, again to both parties. It's not only the patient, the performer also has to be comfortable during the procedure. So coming back to the aseptic conditions, as you know, you have to have strict hand hygiene. Hello, Rajita. Rajita?
Yeah, madam.
Can you hear?
Yeah, madam. Can hear, madam.
So I started.
Okay. Come on. It's okay, madam. You can continue, madam.
You can hear, right? Shall I continue?
Yeah, can hear, madam. Yeah.
Right. Okay. So it's important to have the hand hygiene. The 5 steps of hand washing is very important. Make sure you remove the germs from the hidden areas in the hand, which are marked in red. You have to wear 2 pairs of sterile gloves. Whether it's in children or adults, the basic approach of vascular access is the same. There are certain things that you should remember. When you are selecting the vein, especially if we are selecting the hand, you have to select the non-dominant hand of that patient, because otherwise all the hand functions during the period of cannulation will be compromised. Then you have to start it distally and then shoot more proximally, because in case if you pick a vein proximally and if you fail to get into the vein, the distal part also will be wasted. So you can't sort of pick the distal part again. The other thing is you need to have a sound knowledge on the venous plexuses or venous arches in your body. So if you can remember your anatomy lectures, there is a venous plexus in the dorsum of the hand and dorsum of the foot as well. The other prominent veins are cephalic vein and basilic vein in the forearm, and in the anterior aspect of the forearm, you will again see a venous plexus, which comprises of median cubital vein and the cephalic vein. So it is important to you need to know about these venous plexuses when you are selecting a vein. There are certain areas that you should avoid cannulation. For example, where the veins over a joint, better not to use. Then if the vein is close to the arteries or deep line vessels, especially the median cubital vein in the elbow, which is close to the cubital artery, better not to use for intravenous cannulation. And this area actually can be reserved for difficult blood sampling. Therefore, not to use for the cannulation. The other things are small visible veins, but which are not palpable, better not to use. you may have noticed in children, there's a practice of splinting to keep the vein stable. But this practice is actually now not recommended because it will deprive with the hand function of the patient. What are the drugs that cannot be given peripherally? For example, drugs like sodium bicarbonate, inotropes, dopamine and vasopressin, calcium gluconate, dextrose, anything above 12.5 cannot be used peripherally. Thiopentone, antibiotic like clarithromycin, fluoxetine. These drugs are not usually recommended to give peripherally because they all have a higher osmolality than the plasma, and if there's a accidental extravasation, there can be tissue necrosis. And in case if you happen to use any of these drugs peripherally, you have to use it with adequate dilution and also give it like a slow infusion. As in any other procedure, the preparation is very important. So what are the equipment that are needed for vascular access? You need to have IV cannula, various sizes. Local anesthetic agents are important too for the pain relief. Then different sizes of syringes for flushing purposes as well as doing blood investigations. A tourniquet, maybe a splint, plasters, bandages, and of course, bottles to collect the blood. So keep everything at your hand before starting the procedure. So you can see in this picture, there are various sizes of cannula, which different colors. So it is very important to select a good quality cannula. Means that it has to be inserted easily. It should permit optimal flow rate, and there should be minimal discomfort to the patient. Should have an injection port, and there should be long cannula life, and also should have only minimal complications. So as in this slide, you can see there are various sizes of the cannula and with a color code. As you can see, when the size increases, the gauge of a cannula would decrease, starting from 0.5 to 2 with the size, and gauge will be 26 to 14. And easy thing to remember is when the purple and yellow cannulas are used for newborn, blue for pediatric patients, pink, green, and white for adults, and gray and brown for rapid transfusion of blood or blood components. Okay, so especially in children, it is important to have a pain relief. Otherwise, they will be troubling you and you won't be able to insert the cannula easily. So there are drugs that you can use, Amitop and Emla. Emla is actually available in our country. The things that you should remember about these pain relief anesthetics are, it will take about 20 to 30 minutes to get the action, which means you have to apply the local anesthetics well in advance of the procedure. And also, it is important to apply it over several places, because in case if you fail to get into a vein, then you will have to wait for another 20 minutes to for the next prick. And the other important thing about the local anesthetic is they both are have a vasoconstrictive effect. Therefore, once you apply it, the vein may not be very prominent. Therefore, it is important that you mark the vein before the procedure. There are non-pharmacological methods to pain relief. One thing is you can distract the patient from the procedure, which can be done by the play therapy. You may use toys, soap bubbles, or you can even ask mom to speak to the baby. And nowadays, actually, the best instrument will be the smartphone. Okay, so getting the vein prominent is a challenge at times. I'm sure you may have, some of you may have tried this during your clinical practice. So how can you get the vein prominent? The things that you could do is, you can ask the patient to clench the hand, to have a kind of a pumping action. Keep the hand below the body level, the heart level. So you can ask the patient to drop the hand by the side of the bed and keep the area warm. You can either dip the hand in the warm water or wrap it with warm towels or warm cotton. The other thing that you can do is to tap on the vein. You can use the tourniquets as well, but it's important that you are not applying too much of pressure because that will obstruct the arterial blood flow as well. Okay, how to pick a vein is a skill that you have to master on. So how do you do it? So you have to first select the vein, the area, the vein, and then when you are doing the pricking, that has to be done not directly on the vein, but choose a point which is about few millimeters away from the vein. You pick the vein at an angle of 30 degrees, go through the subcutaneous tissue for some time, some distance, and then only through the subcutaneous tissue you should pick the vein. Otherwise, because there should be a the skin layer will act as a barrier and also will prevent leakage, and the stability will be more if you do it in this way. Right? So there should be always some tissue in between the skin prick and the entry into the vein. So how do you know whether you are in the vein? If you see blood in the flashback chamber, that means you have pricked the vein. So at that point, you have to insert the cannula a bit and then remove the stellate. Okay, let's discuss about a couple of problems that we can get by inserting the cannula, right? Just think about a situation where you have inserted the cannula and you saw the blood in the flashback changer. You advance the cannula a bit and you have removed the stellate and you realize this flow has stopped. So what has happened here? As you can see in this picture, the stellate is pointing few millimeters beyond the catheter tip. So what would have happened is, as soon as you enter into the vein with the stellate, blood would come to the flashback chamber. But when you are removing the stellate, you will realize the catheter is still outside the vein. Right? So how to avoid this situation? So what you have to do is, once you pick the vein, once you see the blood, you have to sort of wait until there's a good flow of blood coming to the flashback chamber, not just appearance of the blood. So when you see that, then you have to advance the cannula further away, and then you have to remove the stellate. The next problem that you may have encountered is with the insertion of the cannula, you will see the blood in the flashback chamber. But upon advancing, you have realized the blood flow has stopped. So what would have happened here? So as you can see, this is a kind of a through and through. So the cannula has gone through and through. So what you should do at this point? One thing you can do is you have to sort of get the cannula back to the vein, then you will see a good flow of blood in the flashback chamber, and then you have to advance it again. But if you use a stellate again, there's a chance that you are going to the same false pathway. So one thing that you can do is you attach a syringe with saline, and while you are giving a flush, then we advance the catheter. So because with the flush, the distal vein get distended so that it will be easy for you to advance the catheter. So anchoring is very important because otherwise all your hard work will be wasted if the cannula is dislodged. So that's one thing that you have to remember is the insertion point of the cannula has to be visible. Then only you will detect any kind of early infection or extravasation of fluid, right? So how you can anchor is first put a plaster above the heart and then anchor the two wings, and on top of that you can insert a tegather. Always try to use the hypoallergic plasters. The sticky plasters are not really good for children. How do you check the patency of the cannula? By giving a flush. If there is no resistance to the flow, that means that the cannula is patent. And it is always advisable to attach a LS connector, because in that case, there won't be any additional weight on the cannula. And you have to record the time and date of insertion, how long you can keep a cannula peripherally, maybe up to 72 hours. So what are the complications of IV cannulation? Most of them are actually iatrogenic. You can form a hematoma, infiltration of the subcutaneous tissue with the solution, causing tissue necrosis, maybe vasospasm, aortic clot embolism, or you can have kind of a ischemia and gangrene to the distal extremities, can accidentally inject into artery, and the other thing is sepsis. How do I identify blocked cannula? You can do it clinically, as I told you. If there is a resistance to the flush, that means there's a chance the cannula is blocked. But if you're using a syringe pump, there are three light indicators, P1, P2, P3, depending on the degree of the resistance. So if you realize the cannula is blocked, what you can do is flush it with heparinized saline and see. If it fails, then you have to resite again. So in difficult cases, you can use the external jugular vein. As you know, the external jugular vein becomes superficial above the sternomastoid muscle when it crosses it between the junction of middle and lower third. To get the vein prominent, you have to keep the head low position, which can be done by keeping a pad beneath the shoulders. And also ask the patient to turn the head away from the side of the puncture. You can ask your assistant to apply pressure on the distal part of the vein, the visible part, just above the clavicle, so that it will stabilize the vein, as well as it will, with the compression, the vein will be distended. The technique of cannulation is just at the peripheral line, first pick the skin and then go to the through the subcutaneous tissue, go to the vein. In rarely difficult cases, we can use the scalp pen, especially in children. So you can use the temporal, frontal, or posterior auricular area. Here you have to use a butterfly cannula for the access. And in newborn, umbilical venous catheter is an important source. In the past, actually, we had to use cut downs, venous cut downs, but it's been rarely used now because there are better ways of inserting cannula. Like in this one, you can ultrasonic with the ultrasonic guidance, you can get into the femoral or internal jugular vein easily. It is a safe and effective way of getting into the central venous access. Okay, so if the patient is collapsed, sometimes you may not be able to get into a peripheral line. So in such a situation, you can use an intraosseous access. So there are needles manually operated, or you can use a ECIO drill, which is a powered device, which will enable the insertion of the intraosseous needle very rapidly. The manually, you can use up to the age of 8 years, but drill can be used even in adults. So all what you have to do is keep the needle perpendicularly onto the place. The sites that we normally use in children are the proximal tibia in the anteromedial surface, 2 to 3 centimeters below the tibial tuberosity, or you can use the distal femur in the anterolateral surface, 3 centimeters above the lateral condyle. So you go perpendicularly until you feel the loss of resistance. So at that point, you can sort of take the blood into a syringe to make sure it's in the marrow. And anchoring is a little different to a peripheral cannulation. As you can see in this picture, what you can do is to stabilize the needle, you can use the artery faucets, and these faucets can be anchored to the limb. As you can see here, there are different sizes. All of them are in the same gauge. It's gauge 50, but the length will be different. So according to the age or depending on the site of insertion, you can select the suitable length of the needle. Okay, so let's see how we can get the draw blood for investigations. So in children, actually, it's not advisable to draw blood directly into the syringe. If you are using a syringe, you can use a scalp vein cannula like in this one, right? Or otherwise, what you can do is drip the blood directly into the tube using just the needle. In the good old days, actually, we used a broken needle, which was very effective, actually, very effective and efficient. But it's not recommended because there have been instances where the broken needle has get lost in the vein. So in some countries, actually, there are special needles for this purpose, but we don't have it. One thing you can do is you can get the scalp cannula like this and cut the plastic catheter here. So you will get the blood directly from the needle. Coming to the capillary samples, what are the sites that you can use? In newborn and infants, you can use the heel samples. In older patients, either the fingertips or earlobe. When it's come to the heel prick, you should not take blood from the back of the heel directly. Right? So what you can do is you can draw a line from the big toe to the heel and from the fourth toe to the heel again. And the area that you have picked is outside of this line, not in the middle, because this area is very vasculated and also you have the nerves there. When it comes to the finger prick, it should be midway between the edge of the finger and the midpoint of the finger. Right? Again, not at the not in the middle, and you should avoid the places close to the nails. And when you are collecting the blood, excessive squeezing has to be avoided because otherwise the sample will be hemolyzed. A few things about the butterfly needles. As you can see, there are various gauges, the various lengths with a color code. Right? So what are the instances where you can use the butterfly needles? Maybe to obtain blood culture, especially if you are not inserting a cannula, or maybe to take blood samples for investigations. Once daily medication as outpatient basis, you can use the scalp cannula. And also, as I told you initially, for the scalp vein cannulation. PICC lines, peripherally inserted central lines, the long lines, right? So if you want to keep a cannula for a long time, you can use a long line, and especially if you want to have the central access. The peripheral insertion sites are the cubital fossa, and also you can use the great saphenous vein. In this X-ray, you can see the cannula tip here, which is close to the tight atrium. Arterial cannulation. When do you want to cannulate an artery? Maybe to monitor the arterial blood pressure, or if you want to take arterial blood gas, or if you want to calculate the cerebral perfusion pressure. So arterial cannulation is important in these instances, right? So there are a few things that you have to remember when you are selecting a site for the artery. One thing is the site should be free of infection. There shouldn't be any kind of a skin break around the area. And also the other thing is there should be a good collateral circulation. Okay? So in the hand, you know, the we normally use in children, the areas that we normally use in children are radial artery and posterior tibial artery. So when it comes to the radial artery, the distal hand is supplied by the artery, the radial as well as the ulnar artery, right? So you can do a test called Allen test to check the collaterals. What you have to do is squeeze all the blood from the hand into the forearm and then compress both the radial and the ulnar artery, right? So once the hand is really pale, you just release the hand on the ulnar artery, right? So if the hand becomes pink, that means the collaterals are working, which means you can safely cannulate the radial artery. Okay, so in difficult cases, another equipment that you can use are the vein viewers. Right? So how does it work? So vein viewer actually project a infrared light, which will be absorbed by the blood, hemoglobin in the blood, but the light will be reflected by the surrounding tissue, right? So that you can get a sort of clear image of the venous pattern. But there are certain limitations. So as it detects the hemoglobin in the blood, there should be good blood flow through the vessels to get the clear image of the vessel. So in a patient who is collapsed, it may not be that successful. The other problem is it will give us just a two-dimensional view. So we don't have any idea about the depth. The little improvement can be done using a pole light, which is in the first picture, right? When you keep the pole light here, of course, you can get some idea about the depth as well. So in difficult cases, especially in chubby children, you can use a vein viewer to find a good vein. Okay, so we have come to the end of the lecture. So if you have any questions to ask, you can use the chat box. The take-home point is actually, if you want to be successful in cannulation, you have to have clear understanding on the basics that I told you, and also there should be a regular kind of practice. So always try to cannulate a patient in the ward when you are doing your clinical practice. No questions?